Good evening, everybody, and welcome to this special session on World Spine Day. For further proceedings, I'll hand it over to our convener of the session. Over to you, sir.
Thank you, Dr. Ashok and the OrthoTV team. I welcome you all for today's webinar on spine and sports injuries. As we all know, today is World Spine Day and the theme is back on track. We know that we all are getting back on track because the numbers of Corona and COVID are getting better and better in all the cities, and the numbers are decreasing. And I hope to continue the same trend all over the country and the globe. Looking at everyone's practice, we do see amount of sports injury patients in spine, orthopedic, and neuro spine OPDs. What all are these injuries are, and because sometimes probably these injuries are not given that importance, and we just take it like, कि हाँ मोच आया रहेगा, कुछ तो लगा हुआ रहेगा in sports, but sometimes it can be dangerous and we have to understand. So we are having a galaxy of speakers today. We have Dr. Ankur Nanda from Indian Spine Injury Center, who is one of the most eminent spine surgeons in Northern India and all over India, we can say. And they have an excellent rehab facility at Indian Spine Injury Center, and they cater to a large amount of national and international sportsmen at Indian Spine Injury Center. I welcome you, Dr. Ankur, for this very episode of Sports and Spine today. Our next speaker is Dr. Gaurish Kenkre. Gaurish is a renowned physiotherapist from Mumbai, and he is the director of Rehab Team of India, and he caters to a large amount of sportsmen, celebrities, and even urban poor as well. Gaurish is a very known figure in Bobat therapy, in physiotherapy, and his connection to sports is huge, and his experience is also quite a large. So we will be happy to see his expertise and experience today in this spine and sports webinar. We welcome you, Dr. Gaurish. Our next speaker is Dr. Himanshu Kulkarni, who is himself a runner and an athlete. He is a badminton player as well. And today we will be seeing Dr. Himanshu's expertise in sports, dealing his experiences in India as well as in Germany, where he is trained in spine surgery. So let's discuss with Himanshu, and he's practicing at Sangli and Kolhapur region of Maharashtra, which is a very, very sportsman friendly region where there are a lot of boxers and kabaddi players, which Himanshu is treating. So we will get his experience from this region. We welcome you, Dr. Himanshu, for this episode. Our next speaker and faculty today is Dr. Sona Kalke. Dr. Sona Kalke, madam, is an associate professor at Sancheti Healthcare Academy and Physiotherapy Institute. She is an astute teacher and academician, and we have her large experience of physiotherapy, teaching and training for sports and rehab in spine. We welcome you, Dr. Sona, for today's episode. And our one more speaker who is having some technical issues, Dr. Abhay Nene, and we are hoping that he will join soon. Will be joining with his vast experience during this show. But show must go on. We are continuing, and today's program we will start with Dr. Himanshu's first presentation. We will be having more of an interactive case-based discussions, and because we are having a mixed set expert in spine as well as rehab, we can immediately talk and discuss the point at the same time so that we can continue the session. Over to you, Himanshu. At the same time, I would like to thank the Pune Orthopaedic Society, who has given us extremely great support, Dr. Narayan Karne and Dr. Abhijit Vahegaonkar, who are the torch bearer of Pune Orthopaedic Society. Also, Sancheti Hospital, Dr. Parag Sancheti is giving us extreme support for this kind of activities, academic activities, and of course, the OrthoTV. Over to you, Dr. Himanshu. Please proceed.
Thank you, sir. Thank you for the opportunity. And I'll be starting with first lecture of mine. Actually, it's a team of stalwarts. So I am the opening batsman and I have a lot of pressure over me. So unfortunately, Dr. Abhay Nene sir couldn't be here. So I'll be mixing two presentations, his and mine, and I'll be presenting it. So I am going to talk about spinal injuries in sportsmen. So whenever it comes to sports injury, the first thing that comes to everybody's mind is knee injuries and hip injuries. So there are injuries which happen in spine, which are sports related. It is a less known topic or less discussed topic, as we can say. So sportsmen, so what is different? So we treat a lot of patients every day. We see OPDs, we do OT. So what is special about sportsmen? So first thing is they have high level of primary fitness. So they are unlike any other patients that you get. Patients usually you get for spine and neck pains are the ones with sedentary lifestyle, the IT engineers or something, people who are sitting down or the riders. So contrary to those, these people have very high level of primary fitness. Most important is strong will to return to the function. So if you treat them well, they are going to do better than any of your other patients because they are very willful and they'll be coming back to their normal functions and they'll work hard for it. That is for sure. Willingness to do aggressive rehabilitation, as I said, and relatively short-term demands, because what happens is when they are in their playing career, which spans about 15 to 20 years, they want to stay fit during that period, and it's your job to provide them that. So if you do that well, if you get them back to their original sport, they are extremely happy. So they have relatively short-term demands and they are actually happy with those results. So what's different? Treat similar to anybody else. Obviously, every patient is same to us, but except in them, time is premium. So any other surgical patient who is taking some time for rehabilitation and you are letting it go, you cannot do that. One sportsman who is in the peak of his abilities or prime of his career, he cannot stay away from his sport for 1 year or 2 years. You have to make it quick. You have to get him back to his sports, his play as soon as possible. So as to return to the function, and it should be full function. So it is not like if you are telling a bowler nahi thoda kami padun ka aise, you run slow, you cannot tell that to a sports person or a bowler. So you have to get them back to their full function as soon as possible. So you have to be sensitive to athlete's need and you have to know what he needs and you have to cater to those needs. So it has to be very careful. So usually what flock we get, so it is mine and Abhay sir's flock. So cricketers, runners, tennis players, football players, hockey players, shooters, archers, boxers. In my region, there are a lot of kabaddi and wrestlers, who come to me with a lot of cervical and lumbar spine injuries. So what are the usual presentations, acute or chronic? Acute are facet strains, disc injuries, acute disc prolapse, and stress fractures. Stress fractures are actually very common. So most of the times, what you suspect in legs is a stress fracture and it is very commonly ignored. Chronic conditions for long-term players are disc and instability and lysis and listhesis. Lysis and listhesis is the most common one. I'm coming to that later. I have some literature over that also. So these are the usual presentations, the complaints with which the patient comes to you. So there has been a lot of literature over it, very scanty literature in India itself, but in Europe and North America, there has been a lot of literature over it. So just to summarize some sports and the amount of injuries the people in playing in those sports get. So soccer, as you all know, it's world's most popular sport. It has been estimated that a lifetime incidence of low back pain in a soccer player is 76% compared to 43% of other players and non-players. 76% is a huge number, as you can see. When it comes to baseball, T2 in a large study, T2 MRI revealed 59% of baseball players showed significant changes of disc degeneration. 89.5% of baseball players had low back pain at some or the other point of their career, the playing career. In gymnasts, I'm coming to the spondylolysis and listhesis part later. In gymnasts, the posterior column injuries, specifically the lysis and listhesis, are more common than the anterior column injuries. It's not that they don't get anterior column injuries. In a large study of 33 female gymnasts, there in a MRI study, with or without back pain, degenerative disc disease was found in 24% of those, and in Olympic gymnasts, it was 63% in till the age of 25, which is a big number. Sorry. Next, as I told you, wrestling. Wrestling can be very crucial. Wrestling can be killing. Cervical spine injuries are very common. I get a lot of patients with these injuries. So the facetal dislocations are very common in wrestling. Cervical spine injuries sustained during wrestling are high profile. Why? Because they are potentially catastrophic in nature. So they considered of 68% of spine injuries in wrestling, the cervical spine injuries, but they do get disc herniations also. So about 28% of the disc herniations are in L4-5 and L5-S1 lesions. So these injuries are also very common in wrestlers. So just to give some examples of some injuries which happen. So it was a 40-year-old test batsman, right-sided neck pain. Batting stance was extremely painful and he was at the peak of his career. So this was his MRI picture. So I would like to ask Dr. Nanda sir, how would you proceed? This is the MRI picture and what do you see here? And if you get a lot of high profile patients at your center also, so how do you proceed with this type of injury or this type of complaint actually?
The gentleman is only complaining of right now of a right-sided neck pain, and
Yes.
you don't talk of any radiculopathy or any nerve-related symptoms. So I would sort of try to look at his overall posture of the neck to start with, how his stance is, how does he tend to sit, and is there any postural issue or not. That would be the first thing which I will start thinking. Now, since this is more of a right-sided neck pain, I would also like to look at, the joint situation, how his joints are at that level, particularly if there is any osteophyte. So as you can see, there is a effusion in the joint and probably a facet capsule injury there. So, so basically the point is to systematically rule out, not to forget our basics, but at the same time have a very high index of suspicion in these, high energy guys.
Yes, sir. So as you rightly pointed out, sir, it was a facetal effusion and that's why he was having unilateral pain. So it settled with local modalities, rest and good amount of physiotherapy. So the lessons, the cause is always there. You have to look for it very carefully.
Yeah. Hi, Himanshu.
Yes, sir.
What could be the reason for only unilateral pain? That's also whether he's a right-sided batsman.
Yes, sir.
And the way he is standing, his stance, and he must be he's keeping his neck probably on the right side more, where there is more of a friction is happening because he must be playing for 6-8 hours practice and things like that. What could be the probable reason for his right-sided only if you facetal wear? That also we need to understand.
His stance. It must be his stance which was affecting his right side more,
Correct.
more
And that needs to be addressed. And even if small amount of correction probably will give a big amount of relief to him.
Yes, sir. Very true.
You can ask Dr. Gavresh what he feels about it.
Yes, sir. Actually, my opinion also would be we have to assess his stance, and because there was a facetal effusion, maybe because he's keeping his neck in one position, there will be a lot of friction happening there, and that may be leading to the effusion. So maybe we work on the stabilizers around that area initially, give him good corrective posture, maybe tell him to intermittently in his whenever he's kind of not batting, he changes his neck position, interrupt that position during that period where the bowler is going back to his run-up. All those opinions would be very important during the initial training phases.
Maybe 3 to 6 months of doing this kind of activities and strengthening probably will change the scenario.
Yes. And we also work on a lot of scapular training. Normally what happens is if the neck is affected, then we normally take the support from the surrounding areas. Like for the neck, we always take support from scapula and the shoulder. They are the regions which are close to the neck. So we work on a lot of scapular and shoulder muscles so that they kind of help take the load from the neck.
Okay. Let's check with Sona madam how she will deal with this situation.
You are mute.
Sorry about that. Yeah. So basically, because it's one-sided facet involvement and the loading is usually by extension and rotation. So the same side. So when you kind of do extension and rotation towards the opposite side, you kind of load the facet of the right side. So you have to look into whether he tends to do that abnormal posture very often during his stance or during his activity, which is loading that facet. So very often you can even test this by examination of the in a corrective position. I think postural training will also go a long way to stop that overloading.
Okay. Perfect. I would like to ask Dr. Ankur if the same cricketer. Hi, Ankur.
Yes,
So
please.
you are on mute, I guess.
Yeah.
No,
If
I'm
the same cricketer is not settling with medications and rehab physio, what will be your next action? You know, he wants to play IPL and things like that, or he wants to play a good level, national level tournament. So whether you'll consider some kind of acupuncture for that localized pain and it's nagging pain, or some kind of pain block.
So we are big fan of these blocks, and I would definitely consider him. And actually, I may consider a plain block even earlier into rehab. So what happens is many a times these are so painful that these guys are not able to do justice to the rehab which is happening and the exercises. And I'm not only talking about this particular patient, but in general. So we also are more aggressive with our blocks. So we would like to get a needle in there and try a facet block in that area. And more often than not, what we have noticed is when they have such facet effusion and facet pains, along with that, there are also trigger spots which are formed in the muscles. So we also like to do a lot of trigger points. So what you were saying, like, acupuncture, it's not really acupuncture for us, but then the trigger point injection, they help really, really fantastic. So I would think of that.
What I realized, Ankur, is that these patients are very demanding. You know, they are not like any other patient because they want to go back to their tournament or matches practice very fast. Even during lockdown period, we were seeing a lot of patients, and they are different breed of people. You know.
Absolutely.
Because
they are the quick fix solution guys.
Yes. You want that, okay.
The blocks are just to aid the rehab. So you have to you have to make the rehab as easy as possible.
Yes.
So another example is 37-year-old rifle shooter, Olympic medalist, acute right C6 radiculopathy, trigger finger, and hypoesthesia. So she was from some other town and she was advised to undergo a surgery for this.
Okay, fine. And now the MR, please.
Yeah, so this is the MR.
There was no neurological any weakness or
only radicular pain.
I think my tendency to consider surgery for cervical spine is very, very low, because I feel somehow inherently cervical spine really settles very well even in larger discs. Also, we have seen a lot of patients really settle very well because there is not much of a loading on the cervical spine. That's number one. If the patient is with only radicular symptoms, I will probably consider a short amount of rest, 3 to 5 days, early rehab, physiotherapy, and IFT TENS, the modality of choice, and maybe trigger point if at all. But definitely, this is not a surgical case to our practice for sure.
So you will consider foraminal block also for this?
I think she will settle with medicines mostly. If not settle, we have found our experience is better. Sometimes in cervical, we consider cervical tractions. Lumbar traction, we are really not using for a long time now. But cervical, yes, in such situations when there is sometimes, it looks very small, but the irritation and the root pain can be very severe at sometimes. So maybe giving that cervical traction, anti-inflammatory medicines, and small course of steroid also probably can be a good idea, and neuropathic medications can be considered.
So it is literature proven that cervical spine acute disc settle with medications very nicely. So early surgery could be an overkill in cervical spine.
Absolutely. I completely agree. There is absolutely no role for early surgery or any surgery. This is going to settle for me.
Yeah.
Ankur?
So
so I totally agree. I think cervical spine is something which is when the disc is operated, usually it's for the deficit, and it's very rare that you have to operate for pain. Very, very few in our practice also.
I would like to ask Dr. Sona, will you consider, some people consider this standing traction. We really don't understand, but the mechanics, number one, will you consider giving traction to this patient? If yes, which traction will you consider? Like 15-20 hours of long traction for 2-3 days, or no traction?
Actually, if you look into evidence, there is conflicting evidence as far as traction is concerned. Even cervical traction, frankly speaking, I'm not a big fan of it. I usually prefer giving manual traction. I mean, with my hands rather, because I can control the amount of pressure that I'm giving.
Okay.
So I usually use a mobilization belt to kind of support my hands, and I kind of give the traction, or I use my forearm to kind of give a traction effect to the patient, and that usually works fine for me. And I'm not, as I told you, I'm not a big fan of the mechanical traction, and it actually works for a very select group of patients.
Now
So
this,
in case you feel that the patient is having relief by manual traction, you can consider mechanical traction for such patients. But in case it's going to give limited relief, then or rather when the patient is really in a lot of pain, it'll be better that you kind of give him some kind of mild stabilization exercises, manual traction. And once the pain kind of reduces slightly, I would like to shift him to mechanical. But I'm still very skeptical about using the traction.
okay. What about you, Dr. Gaurish?
So you're on mute. Gaurish, sir.
Sorry.
Yeah.
Yeah, I agree with Dr. Sona ma'am, because in my practice also, whenever in early days when we tried traction, there are some very minimal patients who get relief when there is more of spasm. So it mainly sometimes helps to reduce the spasm around the cervical spine, but there are chances that it can actually increase the radicular pain. So that's why there are a lot of contradictory schools where they say that traction, some schools follow traction, but there can be a lot of don'ts which can come out of traction. So ideally avoid.
Okay. So it's a institutional practice. It's where you're trained, and maybe the overall trend for traction looks absolutely no in the discussion. So I think there is a very small role of kind of traction. As this patient was advised surgery, she must be in a lot of pain. So all these options, we are just thinking, what all things can really give her relief. Because the surgeon who has advised surgery to an Olympian must be, he must have thought something, or, maybe he wants to give her early pain relief. But we are thinking from sitting here, but clinically we have not seen the patient. But I think that's the right way to go, giving a good anti-inflammatory medications, settling her pain, monitoring her well. Yeah, there's a soft disc we can see in the foramen. Maybe, unless if you are really a good expert, you can consider giving a root block. But otherwise, this will settle. Sometimes I think there is a good role of steroids in such kind of cervical discs. Lumbar we really don't prefer much, but cervical we have our own experience of good settlement of this kind of soft disc in cervical spine. Yes, what did you do, Himanshu?
So that's what. So rest, gabapentin derivatives, do's and don'ts, and aggressive rehab. So we actually gave her steroids initially, oral steroids, and she was given a USG guided transforaminal block, which are considered the safest. So she was given a USG guided transforaminal block, aggressive rehab. We had actually planned in SOS, but we gave her and she did absolutely fine. So she didn't need a surgery. She went back to her sport probably 3 months later. So it was
nowadays there are good pain specialists who are doing these procedures, very well trained.
It was done by her. It was a USG guided foraminal block.
Perfect. Okay, good.
Okay, next is 34-year-old test opening batsman, acute pain while playing a pull shot, had to get back to the game stat. There was no red flag as such. There was no radiculopathy. There was no neurodeficit as such. So this was the MRI. You can see L5S1 is a fresh annular tear. So Dr. Shailesh sir, your opinion?
No, I think this is a very classical image. What we see, high demand cricketer and long-standing, long practice hours, long practice as well as long games and many games in a year. So this is very, very classical. The load comes either on L4, 5 or 5-1. And we can see a classical annular tear here. There's a dehydrated disc disease in the lumbar spine, probably L5S1, because we don't have the whole spine, but this is L5S1 annular tear. And I think again, core strengthening, they are really very good athletes. So it's not a right thing to tell that core strengthening, but that's the only thing which we have. A good core strengthening, anti-inflammatory, couple of days of rest, maybe 2 or 3 days. That's what normally we prefer. Hot or cold packs. This should settle.
Yeah, I wanted to ask Gaurish sir, what is the protocol about rest? How much rest is adequate and how much rest is more, and how rest is required or no? So there are a lot of contradictory opinions about amount of rest or the days of rest that you should take. What's your actual opinion about it?
So we normally look for red flags like leg pain. So if there is leg pain, then the rest duration can be more, but maximum rest what we advise is 1 week, not more than that. So 1 week is the time for the person to settle. But in that 1 week, they are allowed to do some bed activities and core activation exercises. So what research says that even if they, as Shailesh sir told, that you don't have to worry about core strengthening because these are sportsmen and they work a lot on core strengthening. But for us to understand, these core muscles are very small muscles close to the spine, and they do a lot of training. These people do a lot of training with the superficial muscles, which are the rectus muscles, which are superficial, abdominal muscles. So many times the abdominal muscles are more dominant than the inner muscles in these people. So we normally do something called as core activation exercises in that rest period. So if the core inner muscles, like we consider three main muscles: multifidus, transversus abdominis, and obliques. So we normally spend time of activation, activating these muscles in that 1 week of rest period. We don't follow anything over 1 week, and in that 1 week we normally hope for the leg pain to resolve. If there is more of back pain, we mobilize them earlier.
Mobilize early. Okay. Same opinion by you, Sona ma'am?
Basically about rest, yeah, it depends. In case there's no serious red flags involved, then the latest evidence suggests that not more than 2 days rest. So the aim is always to put the patient back into limited function as soon as possible. So usually nowadays, the latest evidence suggests please do not suggest rest for more than 2 days unless the patient is really, really having some serious red flags or the pain is quite severe enough to kind of stop activity. Even with extreme pain, the patient should be advised after 48 hours to move about, be up and about on his feet. And the pain should be the guiding factor. I mean, that should be dictating what he can do or he cannot do. But my opinion about rest is similar. I mean, I would like to go by evidence saying that keep the bed rest at minimum and try to promote functional activities, light functional activities, as soon as the patient can manage. About core stability, again, the latest evidence suggests that apart from these three muscles which Gaurish mentioned about the internal oblique and the transversus and your the third muscle being your why am I forgetting that? So basically, apart from the core, it's also the rest of the obliques, your external oblique also, which plays a good role. Your the muscles which are kind of even slinging along with the back, your multifidus and other muscles also. So basically, it's going to be an incorporation of all the muscles rather than only the core. So the latest trend is going a little away from only core stability exercises and engaging the other muscles also, which may play a role in stabilizing the spine. So moving away from the inner core to the outer core, you know. So that is the latest evidence and kind of engaging the muscles in the entire kinetic chain, especially when the patient is up and about, while he's standing, while he's walking, about kind of trying to teach him what is the spine neutral and seeing whether he can maintain that during his functional activities, especially in the acute phase. So the core automatically gets activated when you're teaching him the spine neutral. So you can work towards that. Yeah, that's my opinion.
Very well said, madam. We completely agree. And overall, I think the world is drifting towards less and less rest and limited activity to begin with. Once the pain settles, you can move on with your activities of daily living.
Yeah, in his sports guys, actually the core is not their big problem because they do a lot of core strengthening. I remember Federer telling in one interview that in 20 years of my playing, I have spent more time on my core strengthening than actually playing tennis and actually practicing tennis. So these guys are very, very much into core strengthening every day. So for this guy, it was actually just an epidural infusion and bilateral facet injections, and he was back to his field within 15 days. So no rest, as you guys suggested. So he was put to physiotherapy from day one. So no rest as such.
Okay.
Next case is 33-year-old long distance runner. acute right S1 radiculopathy with toe plantar flexion weakness. So now weakness is a serious thing in a long distance runner because it changes your stance altogether. So this is the picture. Dr. Nanda sir?
Yeah, so I think this is the tricky one. You said there's a toe plantar flexion weakness. Where MRC grading? Was it a grade 4, grade 3 sort of thing?
So it was grade 3.
It was grade 3. So you see, this is going to completely change his, not even the jogging pattern, but also his walking pattern. It's very, very important. His ability to go up the stairs, his ability to actually walk without a limp, especially with these S1 weaknesses is, notorious. A person can tolerate a little bit of a dorsiflexion weakness, but this thing creates a lot of limp. I'm inclined to be more aggressive with this person. And even though we know that the lumbar disc herniations can settle with time, but considering the fact that he's a runner, has a S1 weakness, I'm going to be more aggressive and, counsel him in terms of getting a surgery done, considering the surgery done as soon as possible. That would be my thought.
Yes, sir. So actually what you said, we actually did, because actual plantar flexion weakness changes a lot of things. As you said, even regular walking is difficult. So long distance running is a different thing altogether. So we have actually went ahead with microdiscectomy. It was actually a tubular discectomy, MLD, and we went for aggressive rehab. So he was back to competitive running within some time. But for this particular case, we had to go for a surgery. So what I'm trying to stress here, so it is a tailor-made treatment approach. So it's a sportsman, you have to preserve his motions altogether. You have to stress more on physio. Everything is agreed. But you have to approach the patient according to his neurodeficits and other complaints. So for as compared to other previous cases, we had to go for a surgery here. Another case, 38-year long distance runner.
Just interrupt you here. I just wanted,
sorry, please go ahead.
Yeah, I just wanted to ask Dr. Himanshu, he was back to competitive running in how much time?
What was the time frame? Yeah, 1.5 months. 1.5 months.
Oh, wow. Okay.
So actually my question is similar to what ma'am is raising the point. So I think Shailesh or maybe Gauri sir can answer this. I have had problems with these guys who have a L5S1 degenerated disc and they get back to jogging and running. Many of them would do extremely well, but some of them would be really, really not happy with their back pain. So and they take a long time to get back, for at least in my experience. So any thoughts on this, how to get, because I would be scared to do this surgery because he's going to come back to me with back pain. This is what my thought is, and that is why I said initially this is a tricky one.
Yeah.
So I think it's one most important thing for this is how much is the willingness of this particular person. That will decide what way he wants to go or she wants to go. Because some people are like very determined, doctor, anything but surgery now. I can do this, I have done, I do mountain climbing, I do cycling, and they are like hell-bent on not doing surgery. And someone is like, can't tolerate, doctor, I want to get fixed it as soon as possible. So that is very, very important to me. And nowadays, because I had seen one similar case and we had given him the similar option. And he preferred to not go for the surgery. And this person continued to come to us for nearly 6 months to 1 year, and it finally settled. The disc still looks bigger, but his pain is settled completely. He's doing a lot of activities now again. Now, it is again a dilemma. I think it is a patient selection is very, very important. If the patient is demanding, I want to go back to my running or things, definitely there is no second thought. We should consider a microdiscectomy, which is a safe, straightforward surgery. Take that extruded disc portion out and he will be back to what he wants to do. So I think that is one dialogue with the patient and the family will be very, very important in this. Not the family, this sportsmen, you have to discuss with them only. That's the first thing. And the back pain, because I think normally it settles over the period of 6 months to 1 year or maybe more, because it's a natural history. So thoda it takes time, but it normally settles. That's what I feel. It takes time for these guys to settle with back pain. Leg pain will get better.
Just one more
compared to all other patients is these people are extremely motivated for physio. For rest of the patients, we have to push them for physio, not with these guys.
These guys are like, they're very, very motivated. Yeah.
They're very
Dr. Gaurish, if I can ask, how much time does it take in your experience for these guys with a good rehab program to be able to come back and sprint or jog? What is your comfortable period and advice to them?
So it definitely depends on the neurological deficit and how early the surgery was done. That's very important. So if the neurological deficit was as in the previous patient, it was grade 3 and the surgery was done early. So possibly in around 6 weeks time, 1 month to 6 weeks time, they should be back to their actual sport training. As you asked me about back pain, what I need to mention is if the time before surgery is more, what they end up doing is, because there is weakness in the plantar flexors or anywhere, any neurodeficit in the leg, they end up putting less weight on that side. And the more weight goes on the other side automatically. That's your body compensation. And what it does is it automatically creates an imbalance in the spine. If there is a left side weakness, your body from the right side is taking more weight. The leg is taking more weight from the right side. And there is a constant imbalance happening in the spine where your right side keeps on training more. So when we train nowadays, we also focus a lot on stability training. So if we just do strength training, they will definitely come back to you with back pain. If we do stability training, then that back pain can be addressed. And sometimes we miss that in rehab. We miss the stability.
I think that's very important point. Yeah.
I just want to, before you go on, I just would like to know a little long-term follow-up about this patient. I mean, in case you can, because 1.5 months post-discectomy back to competitive running and considering the loads that come on the spine.
Competing, ma'am. He started training after 1.5 months. Training to his full capacity.
Okay.
He didn't go back to playing actually the tournaments in 1.5 months.
Okay.
So another example, 38-year-old long distance runner, left-sided back pain, close to marathon time. And this time it's just back pain. Sorry. So it is no radiculopathy as such. So this is what the MRI picture reveals. So you can see it is a sacral stress fracture. So treatment protocols.
A lot of surprises can be there. We think about lumbar disc or muscle, and eventually examination is important. When you examine such kind of fracture clinically also, you probably will feel the tenderness area point, and maybe some kind of flexion abduction tests will be positive in this but yes, this is a possibility, and which is not so common, because they are getting good vitamin D, they are running in sunlight, 38, very young patient, a young person, very unlikely. So what is the reason for this, Ankur?
So very difficult to say the reason. Probably I would think as, vitamin D is something which is definitely on my mind. So interestingly, as you said, they are out. The only problem is when they are out, they are not enough exposed to the surface area is not enough exposed to generate that amount of vitamin D. But usually these are more, aware type of sportsmen and they take care of these things. But I think for me, the takeaway from here is I'm a little bit of a paranoid surgeon. So usually I always insist the radio technician in the hospital to always take coronal cuts for people where there is a, excruciating pain in the lower area. And I'm expecting that, okay, this is too tender than my expectation. So usually in my prescription, it would go out as a please take coronal cuts, because all these MRI guys would try to save time and just take the sagittals, and this is going to get missed in the sagittal. So I think it's very important practice to include the coronals also in our investigations.
No, we also follow the same in all the lumbar spines. We do the coronal of SI joint by default. It has to be there.
It should be done. Yeah, I think that is the way to go.
Yeah.
Okay. So I'll just go fast now because I've already eaten up 40 minutes. So this is another 29-year-old test bowler, left-handed, right-sided back pain, and it was specially on the follow-through swing. So I'll come to that terminology later. So this was the pain. This was the clinical scenario. So as you can see, there is a fascial hypertrophy. So he went home. He went home very fine with a facet joint injection and a proper rehab. So another example, 28-year-old fast bowler, right leg radiculopathy on landing. You can see there is a foraminal compression, parasympathetic foraminal compression. So he was actually treated with a root block, that is a foraminal block, and rehab. So there is a lot of literature about the cricket and fast bowlers back pains and leg pains. It is called as the crunch factor. So what is a crunch factor? It is defined as the instantaneous product of lateral flexion and axial rotation velocity of the lumbar spine. So how does that actually happen? So this is actually at the time of bowling and landing on the ground with, you can see here, the crunch factor, that is lateral flexion and axial rotation. So this is called as a crunch factor, which troubles a lot of fast bowlers. You can remember all the names and they have always gone through back pains. So this is called as crunch factor. Crunch factor appears to occur just after the front foot impacts on the ground. So 91% of back injuries in the bowlers are due to crunch factor. So this is a known statistic.
Yeah.
Crunch factor also affects the tennis players during the serve motion. So it is again the lateral flexion and axial rotation velocity, and they land on their front foot. So you can just imagine any big tennis player. So I have just given 3 examples here. Andre Agassi actually had to retire because of his back pain. So the crunch factor also plays a role in tennis. So the motion of serving leads to wear and tear of the back. So again, it was a similar example. Tennis player, left-sided back pain affecting game. So he had a facet joint strain, arthritis due to recurrent rotatory loading. That is the crunch factor. So he underwent injection, rehab, and ergonomics. That is the education and change in the playing style. So again, 19-year fast bowler, left-sided low back pain, performance affected. So this is a very common and very peculiar injury in adolescent and early age athletes. So I'll come to that paper later. So here you can see there was a hot spot on bone scan. So this you can see there is early lysis. So rest for 6 weeks, and he was off all the contact activities, 6 weeks of light contact activities and rehab. He went back to his regular playing days. So even gods have spondylolysis. So I am coming back to spondylolysis now. Even this is the player. So it is a well-known fact that Sachin Tendulkar suffered from back pains. He actually had spondylolysis during midpoint of his career. So the etiology, I won't go into details. There was a landmark paper in 1998 by Micheli et al. It was done about back pain in young athletes. So you'll be surprised to know the statistics. So they compared 100 adolescent athletes with back pain in group 1 and 100 adolescent non-athlete population in group 2. So the amount of back pain was 74% in group 1, that is adolescent athletes eventually had spondylolysis and listhesis, and that percentage was only 5% in non-athletes group. So it is a high number for athletes. So it was 74% when you start early in your career. So this was the percentage. So the repetitive extension and twisting of lumbar spine requires in soccer, gymnastics, football, and our place cricket. So most common presentation is a patient with low back pain that is exacerbated by spinal extension, but it rarely has a neurological involvement. So you can suspect a lysis in these patients. So early diagnosis of lysis, that is impending lysis. This was again a landmark paper in 2005. You can see in fat saturated P2 images. So here you can see there is a marrow edema in both areas. So you can see in the sagittal cuts also. So if you can detect these changes early, if you can detect the impending lysis on the MRI, it is better. So you can save a lot of rehab and a lot of trouble for the patient in future. So what should be the clinical approach for this patients with lysis? So obviously the X-rays have to be standing and dynamic. So the standing loading X-rays where you can actually see if there is some movement. CT scans, MRI scans, and as I said earlier, in early lysis patient, bone scans can be very effective. Bone scans can be very useful. They can actually pick up bright signals and they can tell you about the impending lysis. So the bones can look for an active lysis or hotspot. It could incriminate the lysis as the cause of pain. Active lysis often heals with good bed rest. So bed rest, it is just given here, man, in 1995. I am against bed rest now since you both have told so. CT and MRI, it defines a hotspot, especially important in dealing with spondylolysis. Look for sclerotic parts defects. It implies chronicity. So it can lead to spondylolisthesis later. So you have to be very aggressive in the rehabilitation in chronic sclerotic pars defects. MRI, you have to see about if there is a decompression, nerve root compression, if there are any degenerated discs. Look for the back pain in lysis.
Yeah, I just would like to interrupt you here, Himanshu.
Okay.
if you understand what happens in lysis, there is a breach in continuity at pars. The pars is broken, and that is creating this in youngsters, high impact individuals, cricketers or tennis players or badminton players. But if you understand that there is a good disc, there is a good anterior longitudinal ligament, and a lot of time there is going to be a non-union of the lytic area. So it is not united, but there is some kind of fibrous tissue which comes and it heals, kind of, some scar tissue comes and it heals that lytic area. So it is inherently quite a stable zone. It's not that if there is lysis means you need to fix the spine, you need to operate the spine. Not really. There is a very good strengthening mechanism which comes into play, and most of the lytic grade 1 or even grade 2 also can settle very well, unless there is leg radiation and symptoms. In our practice, we have seen a lot of patients with lysis without any listhesis. They really get significantly better. Only symptomatic, I will say, the percentage will be less than 10% of patients who really need any intervention, like a block or a surgery. So this is inherently a stable situation. Don't get scared or don't get frightened that this is something which is a very, very terribly unstable situation. Not really. This is a reasonably stable situation, and we need to really treat it well with good rehab, good understanding of the condition. What say, Ankur?
I couldn't agree more. And just to add on to it, with the lysis and even a minor grade 1 listhesis also, they also go on to do good. So I think the key point should be the ability to understand that the disc is normal, the ALL is intact, especially if it's a unilateral lysis. If it's a younger patient, they have a very good prognosis for that. Yeah.
Absolutely.
Yeah. So surgery in these guys is a real overkill. So you shouldn't rush for it. So always try to locate the source of back pain in lysis. Often the source of back pain in lysis is a degenerated or black disc below the level of lysis. This could also happen. So you have to monitor the progression, standing lateral dynamic x-rays to document the definite progression on the serial x-rays, and a change of 10 to 15% slippage or 4 to 5 mm is necessary to panic a little. So unless this amount of slippage is there, you don't have to worry about anything. The patient is absolutely going to do well with conservative management. Prognostic factors for progression or degree of slippage in the initial examination and posterior element dysplasia. So if it is a congenital issue or it's a dysplastic listhesis, then you have to think differently and you have to act differently. So lysis management. So this is a big thing. Let's not go into surgical management right now.
Yeah.
So this is how it actually happens. So just to sum up, so the athletes are special. You have to be sensitive to their needs because they are actually making their living on that thing. So you have to get them to work as soon as possible. Treatment principles remain the same, but you have to raise the bar a little as compared to other patients. Use all investigations deemed necessary to accurately diagnose the condition, because the actual diagnosis is going to be the key here. And resist the temptation to overtreat. This is the most important part. As we have seen already, most of these conditions do well with conservative management. So don't go for a surgery right away. It is absolute overkill. So you have to rely more and more on your colleagues in form of physiotherapists, and they will do the rest. So thank you.
Thank you, Himanshu, for a wonderful presentation, and you clubbed Dr. Nene's couple of cases as well, very well. And we thank you both for this wonderful discussion session, because we tried to cover most of the things in this first presentation. I would like to request Dr. Gaurish to share his screen, and we will go only now 8 to 10 minutes per presentation so that we can get all the time, and we will try to stick to time.
Yes, sir. I'll go through the presentation quickly.
Yeah.
Just 1 minute. Yes. So as we all know, posture is the most important thing, because spine actually takes care of your posture, and we all should know that we should not be a comma, rather we should be like an exclamation. So it's very important. An erect posture will take care of your injuries in life. So that's very important to have a proper posture. Now it's very important to hit the bull's eye. What do I mean by that? It's when you see a patient, you first need to know, is the patient moving poorly because of pain, or is the pain the reason for his poor movement? That's very important to know. So as Himanshu sir said, assessment is the key. We need to assess and we need to reach the diagnosis. So identifying the problem, is your posture leading to your problem, or is your pain leading to your wrong posture? That's very important. So in spinal problems, assessment is the most necessary thing. So identifying the problem. If the pain is the reason for your problem, then you have to kind of identify the injury, treat the injury. If the injury, after discussion with the spine surgeon, if they feel and if we feel that it's going to be treated by rehab, then we have to plan a proper rehab. Nowadays, there is a concept of prehab where we kind of train the sports people for their sports. So in that case, we need to know the predisposing conditions. We need to know the athlete as a whole, so that we can foresee the injuries. If we foresee the injuries, we can prevent the injuries, and that helps in long-term maintenance. That's why a proper team physiotherapist or a team doctor who stays long-term with a sports team is very important, because then they can foresee the injuries, they can know the athlete as a whole, and then they can affect their performance or help them improve their performance. So that's very important. So knowing your treasure. So our spine is actual treasure in our body, because we know that spine has 33 vertebrae, 13.5 million neurons, 100 joints, 220 ligaments, 120 muscles, and 1 spinal cord. So it's like actually a treasure box. So we need to save it like a treasure box, like a tijori. We have to actually keep it like a treasure box, and it's very important. And that's why the spine is called the highway of communication, which sends approximately million information to the brain and then back to the different parts of your body. So it's very important for us as therapists or as an individual sportsman to treasure that, treasure your spine as a whole. So that's very important. So to treasure it, we need to create a win-win situation. So we need to have a healthy lifestyle. We need to stay active, eat healthy food. You need, if you're a sportsman, you need to stay hydrated. It's very important. Maintain a healthy weight. Your stress levels have to be down. You have to sleep well. You need to update on recent advances, like when Sona ma'am explained that the focus is shifting from the inner core to the outer core. So you need to be aware what's happening recently. Now the rest duration initially was 1 month, then it changed to 15 days, then 1 week, and now 2 days. So you need to be aware about the recent advances. You need to be aware about patients' other problems, the chronic problems, and kind of have an individual program for them. And exercise is the key. So rehab is the most important thing which can keep you fit and healthy throughout your career as a sportsman, or else in individually, whoever, including a sedentary person sitting in the office, again, they need to be active and keep exercising. So healthy spine is very important. So if you do something today, then your future self will thank you for those yesterdays. That's very important. So the last figure here says that a man too busy to take care of his health is like a mechanic too busy to take care of his tools. So that's again an important phrase to know, that if you are too busy in taking care of your tools, you won't be able to kind of take care of your spine. So that's very important to give that attention to your spine. So for that, for achieving your goals, as a sports person, you need to make sure that the actual sport is not the only thing what you can do. You need to have a lot of preparation for the actual sport or the task activity. Then only you can keep your spine healthy and the other joints healthy. And that includes a good warm-up, a good aerobic session, a good amount of strength training, a proper supervised strength training, and a good cool down session. So these everything need to be included in and out of your main sports activity, what you have been doing. So that has to be included. You cannot skip any of these contents. Why it's important is because it has a lot of psychophysiological effects. It helps in your muscle adaptation, your soreness and your muscle damage markers are improved, range of motion and stiffness. It helps in your cardiovascular and respiratory system. It helps in your stamina building. It helps to stay positive during the sport. Your sports performance increase. It helps you to prevent from injuries. The outer circle will happen only if you do the inner circle. So inner circle has low intensity resisted exercises, low intensity exercises in what? It's like, again, those 4 phrases: warm up, aerobic, strength, and cool down. So if you do that, then you achieve that outer circle, and then you achieve that innermost circle, which is your main sport. So that's very important to carry everything together. So this is just why warm-up is important, because it helps to better your transmission of the nerve impulses. It helps to prevent injuries. It helps to get the cardiovascular system ready for the sport. And you can actually have your performance better when your inner body temperature is warm. So you need to have a baseline body temperature before the actual activity so that your muscles are supple enough to respond to your function or the demand. As the warm-up is important, again, as I mentioned, the cool down is equally important. So it improves your sports performance. It has a lot of physiological benefits. It also has a psychological benefits because it helps you relax. And it has a long-term effects, like it helps in injury prevention and a lot of adaptive responses. Another important thing in sports is hydration. So because of your continuous activity, there is a lot of dehydration which the patient may not, the athlete may not know. So dehydration leads to increased body temperature, elevated heart rate, increase in perceived exertion. So you have to keep hydrating to improve your performance, endurance, coordination, concentration, as well as there are negative effects when the fluid deficits are as low as 2%. So you need to stay hydrated in your sport. So tips to prevent trips. Nowadays, there is a concept of passive warm-up. So it's again a recent concept, passive warm-up, where the therapist or the team doctor passively gives you different range of motion exercises. These help to elevate the core and the body temperature during the transition phase. That is the period after the warm-up to the beginning of the actual sport. Again, different athletes have different kind of training. Like in running, the new concept says that complete at least one race pace effort for the middle distance races and at least 5 near race pace efforts for sprint races. So what they say is, when you run, there are 4 things in running. There is a reaction time, there is an acceleration phase, there is a maximum velocity where you reach, and there is a maintenance of that maximum velocity. So when you train for running, it's very important to train that third phase, the maximum velocity. So we should try and hold that maximum velocity as much time as possible. That is something which is recent advances in running. Cycling involves shorter, low intensity aerobic efforts, followed by a few activation sprint efforts, which is more beneficial in enhancing their performance. This is because our talk is also related to sports. That's why I covered this in a small this thing. The swimming. In swimming, there is a use of one race pace effort, again a maximum velocity effort when you are training at the end of the pool. So at the end of the warm up, when you reach the end of the pool, you try and do one race pace, maximum velocity effort. Then you add some dry land activities like core strengthening exercises. And then there are these passive heat maintenance devices which nowadays are used mainly in swimmers, because the normally the pools are not temperature controlled, and after doing warm up you land up in a pool and the temperature goes down. So there are these passive heat maintenance devices such as heated athletic costumes. They help to sustain the body temperature during a long transition periods between the warm up and the actual sporting activity. Again, football, perform warm-ups as close to the game as possible. And you have to also make sure that you repeat the sprint drills during the second half. When you have that break, you have to repeat the sprint drills so that you minimize the decline in the core temperature and your muscle temperature in the half time when you're waiting. Yes. Thank you.
It was very enlightening. Thank you, sir.
Thank you.
Shailesh, sir. Actually,
yeah, I think in the
Shailesh sir is missing.
Yeah, I think in the interest of time, Dr. Gaurish, thank you for the excellent presentation. And can I go on to share my screen?
Yes, yeah, I think go on. So sorry, my video was on mute. And please go ahead, Ankur. It was an excellent presentation, and a lot of things which were needed for us to understand were covered up by Dr. Gaurish. So we'll go to the next presenter, Dr. Ankur Nanda from Indian Spine Injury Center.
So I have to put up a disclaimer here. After speaking after Dr. Gaurish, and which I'm going to be followed by such an eminent personality, Madam is going to speak after me. So I'm not going to dare to show that I know a lot about rehab. I'm just going to be so my presentation is basically just to make us aware about when a sports person comes to you, what is the things which as a doctor you are going to look at, and how your rehab team is going to help you, and just a few cases. So my work has been made quite easy by Himanshu, because I think he covered so extensively and fantastic cases. So I don't think I need to sort of stress on the importance of, so we know that back pain is a very common ailment, and all these sports, we know Neymar, how he got a fracture when he was playing the World Cup. And it was so heartbreaking personally for me as well. But, we know that these problems are there. Spine is something which is very important for a sports person. And we know that these injuries are actually very different from a normal spinal patient who's coming to your OPD. And the reason, as very beautifully outlined by Himanshu, these guys are, high energy, high demand individuals. They want quick fix solutions. And also it is very important to understand that certain treatments may be more beneficial for a particular set of players, and they may not be as beneficial for the other set of players who are in a different sport. So you have to understand that the treatment has to be very, very tailor-made in these, and an individualized treatment plan for an individual person within the sport may vary depending upon his body habitus, his balance issues, and things like that. So basically, it requires you to use your brain, how I'm going to deal with this patient. And it's not going to be a run-of-the-mill patient. That's basically what we have to understand. So I tried to look at, what are the common problems. Himanshu had divided them into acute and chronic. But more or less what we get people is either coming with pains or then with real issues, which we call spine surgeons as the lumbar disc herniations, lysis or listhesis. When we talk about sports injuries, of course, we're talking also about fractures. So fractures can be major or minor. When we're talking about fractures, which are transverse process fractures or spinous process fractures, usually these are stable injuries. A good rehab program with some amount of analgesics will help. But if you get a major fracture, which is usually very unlikely in the sports in the Indian scenario, but in scenarios like rugby, American football, these are scenarios where we have seen people have got serious injuries, especially the cervical spine injuries. So we got to be more aware about these fractures in that scenario. Himanshu, again, he explained very beautifully about how fast bowlers goes on to, have a lot of movement in extension and rotation, and how he gets on repeated movements tend to get back pain. And these young bowlers, which are between 16 to 24, are more exposed to, they are at a more risk of stress fractures because of the repetitive loading of the lumbar spine. And symptoms usually would be just back pain, and as they settle down in their bowling action, a current which runs down the leg. We know that lysis and lysis is something which the soccer players have been really troubled with, and we know it happens because of repeated stress and trauma. Again, volleyball players, we see a lot of volleyball players here in Delhi, because the Haryana residents, they are big volleyball players, they are big wrestlers, and we see a lot of them. And in volleyball, usually the pain will result either from leaning forward or leaning backward. So they are leaning forward when they are trying to, get a pass or follow through on a serve. But when they lean back, they are basically trying to initiate a serve. So it's very important to ask these players whether the pain is more on bending forward or bending backward. And usually they can be helped by, training them by our rehab specialist, how to initiate these movements with gluteal muscles in the buttock area, and not by, other muscles. At the same time, we get patients in Delhi, especially lawn tennis players, who tend to start getting back pain while they serve. So they are very good while they are playing, but while serving, some of them get a lot of pain, and it is again because of their posture, the way they are bending their backwards and not doing the proper posture. So working on these on their serving action would help them. At the same time, we also see in lawn tennis there are abdominal muscles which undergo strain, and this is usually when they are using an open stance forehand strokes, and then the abdominal muscle injury involves abdominal muscles can get injured. So basically, we know, and we have been discussing this, that a good rehab structure program is the way to go. It's very important to recognize which are the important muscles which are controlling a pelvis, and a pelvic stabilization with a lateral hip and a gluteal strengthening program will go a long way in getting rid of these pains. Important is to get a proper body alignment, which allows the muscles of the body to work in a proper harmony. I just got some of these pictures to show about how there are different types of exercises. Of course, I'm not going to go into the detail of these, but then we know that there are different exercises which can be worked upon. They can be dynamic stability exercises, they can be rotary stability exercises, and we must understand that these exercises are graded according to the level to which the particular individual patient or the player has reached, and we need to keep continuing challenging them to the next level. Just a quick word on something which we have been working on. So this is you can use now technology to basically better understand your player, better understand what are the needs of your player. So like this is one of the machines which we have recently acquired. It's called the Walker View, wherein this it helps in identifying the abnormalities during walking as well as in running. It doesn't require any electrodes to put. Basically, there is a 3D camera in the front, and it can, within 5 seconds, it recognizes the patient on the runner on the belt, and the 3D camera is able to detect the position of the joints, the movement of that subject. Then there is a load cells on the underside, which can basically assess your length of your stride, of your step, what is the pressure it is being generated on both the legs. And then the computer software basically fuses all the data which is getting from the load cells, from the 3D camera, and from the speed with which the patient is walking or running. And then they can come up with a simulated profile of the athlete with which the physiotherapist or the rehab specialist can work with. There are different machines available now. So this is one of these machines which basically Dr. Gaurish was talking about, getting your balance correct. So this machine is able to evaluate the posture and balance control, and it is able to check in anterior, posterior, right and left direction about the pressure center and how you are sitting, how your core muscles are working. And this can help in not only in the standing but in the sitting position. So these things become very important for, let's say, an archer who's trying to take a long shot, or a shooter, and how his standing stance is, where his muscles need an improvement. So after the initial assessment with this type of technology, the software system can actually create a customized athlete profile, and then these all training parameters can be put it into on pen and paper, and then the therapist needs to work on these parameters. So it's something which is the next level. We know our basics, but we can fine tune with these machines. So these machines are not something which is very, very necessary, but at the same time they can get you that extra edge. I just put 2 or 3 cases just to show how these different people can be treated. So this was a 24-year-old football player who came to me with a lot of back pain, and I assessed him initially. And to be frank, in the initial X-rays, I thought nothing was wrong. We got his MRIs done as well, but with a good rehab program also, he was not improving. And then I decided 6 weeks later to get a CT done. And what I found was that he had a unilateral lysis on one side. Again, we put him up for rehab. We gave him a brace, but since he was not struggling, he was not stabilizing. So we went ahead and we did a pars repair for this. So this is basically a smiley technique, which is popularly known as. What you do here is basically you expose the muscles minimal invasive. You get your screws into the same pedicle, and then you fashion a U-shaped rod, which is passed in the interspinous area. And as you attach this rod, you are able to create a compression on the lysis area. At the same time, before you attach this rod, the lysis area is made raw. Local bone graft is taken from this local lamina and is put in the lysis area. And this is something which gave a lot of relief to the patient, and he was able to get back to his playing practice in around 3 months or so. So this is something which I'm not saying that should be done for people as a routine, but those people who have failed a good rehab program, failed bracing, and still are not able to actively get back to, let's say, things like soccer, then this is something which can be done. This is another patient of mine. He was a basketball player, 6 feet in height, and he was having continuous some numbness in the legs, no significant pain, but he came down. So he used to still go on to play and do his sessions, but at the same time, he did give history of not being able to walk beyond an hour or so. And one fine day when he was taking a 3-pointer, and when he landed back, suddenly he got a sudden jerk in the back with shooting pain down the leg. And this is how he came to us. And you can see that he had a fresh HIZ in the L4-5 disc. But also, to my little bit of surprise, I found that he had a constitutional narrow canal. And even with this sort of canal, he had been playing basketball for the last 3 or 4 years. So I think it was both an acute on chronic situation. There was an acute HIZ herniation along with this type of canal. And I was a little bit worried about him because he wanted to carry on basketball. And I felt that this is like a sitting time bomb and may give him trouble in the future. So we went ahead and did a microtubular decompression of this patient. And he just came over to my OPD around, I think 5 days back. And he's now 4 years down the line. You can see the date is 2016, and he's still playing basketball at the national level. So this is the other way of looking at these patients. Another patient, he's a 19-year-old boxer, and he came with this type of X-ray. He had a lot of back pain. And if you see here, there is a limbus vertebra in the lumbar fourth. And we thought that probably there was he had got some trauma or fracture, but actually he didn't give any history of trauma, but he had been, doing really rigorous workouts. And he was having this pain since last 6 months in the facet. This pain was more on bending backwards, and when he was taking these punches, especially to the right side. And even though the MRI didn't really give us much, but then we realized that probably this is a facet pain. And we went on to give him a facet block on the right side, and his pain has remarkably improved. And we even went on to do a radiofrequency ablation for him because the pain recurred after the block, even after rehab. So we did an RF ablation. So this is just a short slide for me, what I thought was relevant. I picked up the summary, and this is my last slide. For a surgery for disc herniation, the literature says that 84% of the patients would get back to playing, but then that doesn't mean that for every sports person it is the rule. So for like in this paper which showed 84% basketball players would get back to playing after a lumbar disc herniation surgery. Usually their first season performance would be a little lower, but their second and third season performance will be higher. On the other hand, the same paper talked about we have to do further studies to basically find out what sort of sport requires what sort of intervention and what are the results in these. So I don't think that we can say that okay, lumbar disc herniation, microdiscectomy would go on to do better for everybody. So that is what this paper talks about, and I think we need more work on that. Lysis repair has been shown to be a higher rate of return to fleet, whereas a fusion surgery has been shown to have a higher dropout in the players rate. So I think we need to understand that probably the fusion surgery, which is usually the most common surgery for a spine surgeon, for a sportsman, may not be the way to go ahead. I think with this, I'll end my slides. Happy World Spine Day to everybody.
Thank you, Dr. Nanda, for a beautiful presentation and the case-based scenarios, which really have helped us also, and the smiley technique. At a lot of times we realize that saving levels is so important, and if you know these kind of different techniques, it really helps us to go at a next level. And I think this technique they use a lot in England also. I've seen this kind of surgeries in Nottingham. They do wonderful presentation. A quick word from Sona, madam. Goresh? Sona,
Yeah, sorry.
Yes,
Yeah.
madam.
So I guess it was a very excellent presentation, Dr. Ankur. I mean, really appreciate. I guess the field of experience speaks a lot, and I think that was evident from the slides that he presented. These are some of the cases that even we have treated. I don't treat a lot of sports patients, but I have treated patients with lysis, listhesis, fractures, but from an everyday scenario rather than more sport-related scenarios. So I'm getting a lot of insight into how sportsmen are a kind of a little different creed compared to the normal individuals.
Yes, Goresh, a quick word.
Yes, I absolutely agree with Sona ma'am. The way they are concentrating on rehab, the equipments what are used in Indian Spinal Injury Center are fantastic. It gives you a visual.
So we'll go on to the last presentation. Is that fine? Sure. And we'll, because Dr. Himanshu, Dr. Ankur, Dr. Goresh, they have done my job very easy. Therefore, I have removed a lot of things from my presentation, which was probably clubbing similar, and I've just kept it more simpler for all of us, and we proceed with this. When we see this kind of players doing extensive training and practice, and to go at a regional, state, national level, international level, they have to really slog a lot. Impact games like badminton, lawn tennis, basketball, kabaddi, all these games are going to have some kind of issues with joints and spine. And when they come to us in our clinic, because they are referred by someone, we always try to treat them very simply by just telling them nothing, sab theek ho jayega. I think we should not do that.
Sir, your volume is not coming through. Dr. Shailesh?
Oh, is it?
Yeah, we lost you audio. Yeah, you're back.
Is it better?
Now it is fine.
Much better.
The video which we played was there or no?
It was there.
Badminton was there. Yeah.
Yeah. So is it now better?
Yeah, it's there.
Yeah. So when we see these kind of impact activities and sports like badminton, lawn tennis, basketball, jumping sports, any activity like kabaddi or kushti, these sports tell us that there is going to be an impact on the joints and spine. These are the two impact things which will happen to anybody. And when these patients come to us in our clinic, we should not say, "Haan, sab theek ho jayega," because they are referred by some big person or some doctor to us. We always try to be more conservative for these kind of demanding patients. But I think rather than doing that, we should try to address the real problem. We should investigate in thorough, because these are very high impact individuals. And the early we diagnose the problem, it's easy for us to treat. And that's what I feel. And this is a very important slide for my practice. I always talk about Tiger Woods, and this is way back 6-7 years back when he was suffering with disc problem. All the American media and world was, because PGA and all, a lot of money was on Tiger Woods. Such a fit person still was having back pain and disc disease. And when we realize even these patients can have, because it's not only core, it's the anatomy, it's the softness of the mechanical cushion which can contribute to trouble. And when these patients have this problem, all world knows about the problem. And this is what exactly happened in the field of golf. And we realized that he had a large disc. There was not much of option because all the conservative options were tackled. He had to undergo a microdiscectomy. And when he went the microdiscectomy, he came back after that and again rocked the world. It is 2014. And Tiger Woods again started going back to fitness and things like that, and again suffered with back pain. He had to undergo one more spine surgery. And this is the real thing for someone who is into sports. We feel that they are the fittest of all, but not really. They are also human beings like all of us. And we always try to think, okay, natural history of a disc. If you see the disc, how the disc was and how the disc is at 6 months, there is a natural history because it is going to settle. Most of the disc patients will not need any surgery. They will need a very good assessment, good understanding, good rehab, good medications, and good supportive care. That's what I normally feel. And most common problems for sports persons are the disc problems, the muscular sprain problems, or strain problems. They are the first 2 or 3 important things which all of us will have seen in our practice. And when we talk about, this is an old article by Kikadi Wills, where it talks about the dysfunction in the disc, then instability, imbalance, and restabilization. How it will happen? If we really assess it well, we evaluate well, this is going to happen. But in high demands, it's not the similar situation. We have to consider maybe sometimes a pain block or some kind of a trigger point injection, or maybe a surgical answer. And this is a recent patient who came to us day before, and he's an international level boxing player, and he's with back pain. His coach and they are really worried because his pain is constant. He's under rehab. He's got very good abs and core. Still, he's having the back pain. And when we understand, a lot of stretch is coming on his lower back. If you see, he is doing it, but he's doing exercise. He gets up in the morning. He runs a lot. He goes to the gym. He does all the activities. So we have to understand that there is something, this can happen because this is natural, this is nature, and whatever we do, we will suffer sometime, and it's the time. Sometimes it can be genetic and various factors, where you're running, which surface you're running, what exactly, which shoes you're wearing, all these things really matter when we talk about sports and spine. Someone like this, and this is again a national international player who came to us, back pain. And this is when he came to us, he said, doctor, I want to go back to my international tour, and you do anything and fix my spine. And this is what the demand was. If you see, this is what is happening is the prevention is actually very, very important. But when we understand that posture, sometimes it can, because it's a lengthy sports, 18 holes or things like that, there are various things can happen, and the disc really can create troubles. This is a patient again who is a national, international level rowing player, and there is a L shape sitting which is constant in rowing, if you understand. And as paddlers, quadratus lumborum easily becomes overworked muscle, and they call L posture. Does it affect? Yes, it is called as kayak back syndrome. And because they have to sit constantly in this posture, so what we have to do is antagonizing action of the muscles, which probably will help, because they really sit for a long time. They have to practice a long. And this is where we have to realize swimming. Is swimming is a good sport? Yes, it's of course a good sport. It's a low impact aerobic exercise, and there's no buoyancy in water. We really can really get significant benefits from swimming. But there are patients who come with swimming problems. We have patients with hyperextension of neck sprain, some patients with diving and having lysis. upper neck and upper back is one of the most commonly having problems in swimmers. We do see patients like who are in hockey team, who are national level players, international players, and who have rocked the big level arena like Mr. Singh. But they do suffer with back pain. And what could be the reason? We have to understand there is a natural tendency for muscle strain, stress fractures, or disc issues to happen in this kind of sportsmen also. And once we understand there can be a collision during the sports and which can sprain the muscles, again in there is a very high impact and sudden jerky movement of the lower back, abdomen, and the hip joint, which can control and destroy your back muscles. At times we have to identify the condition, work on day-to-day posture, stretch your tight muscles, mobilize. You need someone to support yourself, mobilize and move your joints. And this is what we need to do in between when you are practicing, not at the last minute, and which we probably will keep you long term better. And sometimes we do see patient, because Pune, as we all know, Commonwealth city, we do have a lot of Commonwealth and national level, international level coaching going on in the stadium at Balewadi Stadium, where we have a lot of patients with shooting. They come to us with neck pain, upper back pain, muscular sprains. And because when we assess, they have to be in this posture for a very long time. And it requires to maintain a steady posture for repetitive recoil of the shoulder, wrist, elbow, and upper back, which probably is creating a lot of stretch on their neck muscles. We have to troubleshoot, we have to fix that back. Again, I will not go into the detail, as we have extensively covered this low back and cricket. We normally see the lumbar spine L3, 4, 4, 5, and 5, 1 creating ruckus or a problem in cricketers, bowlers, and batsmen. Lysis is one of the very commonly seen problem in cricketers, as well as the disc. These are the two things. And if you see the bowling action, we have to understand the way he's bowling. We have to do some minor correction, like sometimes the batsman can play a pull shot, he's keeping his stance and left leg, the alignment can be slightly changed, drifted, and you really can get that axis better, where you can get his back and abdomen in a proper posture for reducing the stress on the lumbar spine, which probably will help. Again, we see these kind of injuries and avid bikers and car accidents in sports really can be life threatening. And one of the bike accident for a sportsman which we have had is this kind of a fracture dislocation, and he came without a neurodeficit. And this is something which is a dreaded thing, which can happen in high impact, high velocity vehicular accidents, and we have to assess them well. Even if he's come to the OPD without any neurological deficit and complaining of neck pain, we have to ask the history in detail, understand the clinical examination, and then treat this problem. Again, a high impact injury to the girl, sports girl, where there was a significant compression in thoracolumbar region. We operated her on the same day of surgery within few hours, and we were really lucky to get her on her feet. And now it is a couple of years, she is completely normal and doing everything. When we talk about sports, few things which we have to understand are very, very common for everyone. One is walking or running, cycling, and third is swimming. These are the three basic things which all the cities, all the district places, all the metro cities, we will have patients and sportsmen to come to us with this problem. So we have to understand this cycling and back pain. I will not go into the detail of this, but three basic mechanisms which can cause back pain is flexion relaxation phenomenon, generation of excessive activation of spinal extensors, and prolonged forward extension. When you see a cyclist who is doing BRMs or long distance, they do come to us with this kind of back pain. They are super fit people, but still they can have this kind of posture which is creating a lot of trouble. Again, we see sometimes they do a wrong posture. We have to have a proper saddle to paddle height, they call it a saddle to paddle height. We have to understand the cadence. These are the muscles which are very, very important for a cyclist, is rectus, serratus, anterior, obliquus, and transverse abdominis. All these muscles of the back, yes, they do play a big role. So before and after cycling, in between, you have to get out, do some kind of stretching, at least 10 minutes stretching for a long drive, long, at least 50 to 100 kilometers when you're planning for a cycling. You have to do stretching. That is very, very important. Break it at around 40 to 50 kilometers, and then again relax, breathe, and do some kind of these activities. If you don't breach the continuity, it's not going to be very easy, because sometimes suddenly you can have fatigability, and that can create a problem. Spinal kinematics, I will not go into the detail of this, but these are the 5 basic mantras for a cyclist. A seat height has to be very appropriate. You cannot keep the knee bent posture. You have to have a proper length of saddle to pedal. Second is the seat position. You have to have the adjustment of the seat in such a manner that you should not be sitting only on the coccyx. At times, we have seen some cyclists are sitting at the tip. That's also not a very good posture. Foot position, what we call the foot is very, very important. Cleats or no cleats. If you're using the cleats, then your cycling will be in a different direction. If you're not using the cleat, it's again a different thing. Posture, when you are, unless you are going in a very fast pace in the last swing zone, you have to keep your posture very, very upright. You don't need to rush for things constant. You can't flex forward and do it. And core strengthening, what is important. And this is one of my friend who is a cyclist with a large disc and doing everything, because he does all his core, and he does 100, 200, 300 kilometers cycling with that large disc, which is settling and almost settled now. Recreational cyclists versus road cyclists. So these are the 2 different basic things which we should understand. A lot of people have to do recreation, like they are going on a weekend, so they are doing this. But a road cyclist, he has a different set of cycle. He has to bend. He has to have that shoulder trunk angle and knee over the pedal attitude. Mountain cycling, unless you are really into cycling, you should not try mountain cycling, because it can create a lot of stretch on neck and back. You have to understand, yes, it's a very, very good sport. You really enjoy doing mountain biking. They call MTBs. But you have to rethink about your backpack strategy. You have to adjust the climbing techniques. Sometimes you're going on a very uphill, or like Sinhagad in Pune, or any other mountain you are planning. So you need to improve your core. Don't stretch too much. If you are having some kind of stress, just get down on the cycle, drink some water, have some electrolytes, and then again walk with the cycle. You don't need to prove anybody, unless you are a great cyclist who is trying for big Ironman or things like that. Otherwise, in routine practice, we should not try to prove anybody. We should take good conditioning for ourselves. Have something, some kind of proteins you can keep with you, some kind of biscuits you can keep when you're going for a long cycling. And at times you can do some kind of physiotherapy if it is available in long cycling. And routine for people who are at home, static cycling also really helps for boosting. Cycling is a very good exercise for the knees, lower limbs, also for whole spine. If you're doing it, it's good for boosting your cardio fitness, helps in weight control, burns a lot of body fat, allows interval training, strengthens your low body muscle. And this, if you understand, this is a great tool for people who really can't go out and do cycling. A lot of people are scared for cycling on the road. Yes, I am not against it. You should really consider static cycling. Walking, how important is walking and back? I think it is one of the very, very important thing, because we advise as doctors, we tell patients you should walk. First thing in our practice, we tell them that you should walk every day. And what exactly happens if you walk and you want to strengthen your core? You have to strengthen your erectors, multifidus, and quadrators. These are the muscles. If you do a slightly larger step, brisk walk, they will really get controlled and strengthened. And that is what we should explain the patients when you are walking, because small steps probably will not help you. And these are the different types of walking: brisk walking, interval walking, hill walking, water walking, and treadmill walking. These are the 5 simple types. This really helps to reduce the back pain, joint pain. Water walking, hydrotherapy, that's what we call, and this is useful for a lot of spine patients. Interval walking, you can you need to walk fast for 20 seconds, and then maybe with moderate pace for 40 seconds. and repeat the procedure. And this is what we normally talk about, is it is good for athletic performance. Brisk walk is really good. I normally recommend brisk walk for people for 20 to 30 minutes, or if you are comfortable, maybe slightly more. And it really helps to reduce weight, increase longevity, for good for your course, reduces the risk of all the other medical issues. Treadmill is also a good option. Sometimes, it's mechanical, but it really helps to reduce low back because your motion is constant. There is not much of a friction. Surface is very, very good, well aligned. Less chances of any other issues when you do a treadmill walk. Hill, it's a recreational outdoor activity. You really will enjoy if you do a hill walking. It's good for endurance. It's good for strength, and it really burns more calories, which is required for even doctors like us nowadays. And yes, you can really walk, and you have to keep a good posture. Your arm swing and posture is again very, very important. And really we have to understand, as orthopedic surgeon, as physiotherapist, as spine surgeon, we talk but we don't do it, because we ourselves we don't do much of, because we don't get time. Nowadays, because of COVID era, we are getting a lot of time, but otherwise every doctor used to be busy. We were not getting time for ourselves, and I think it is important for us to wake up and start giving time for ourselves. I'm not going to talk a detail because most of us know the right posture while walking, and it's important. You can use the pedometer for this. And last but not the least is swimming and spine, and how it is useful or what really can happen. It's a unique thing, as I told. Buoyancy in water is less. Normally we tell it's very good for cardiovascular training. It's good for your joints and muscles. What really exactly happens, which are the important muscle in swimming? If we understand, they are the trapezius, they are the latissimus, they are the quadratus, there's the erector spinae, the rhomboides, and the bicep femoris and gluteus. These are the important muscles involved in swimming. And the injuries which can happen is shoulder and cervical spine. There can be some kind of stretching injuries. Common is the shoulder injury, the glenohumeral instability. Mechanism of injuries, overuse. Basically, it's an overuse which can happen. Hyperextension of cervical neck spine can lead for sometimes breathing issues. And what all are our goals when we talk to the patient? I think the problems with swimming are comparatively very less, but there are a lot of things which really we can do. Is correction of improper swimming technique. That's the most important thing for a swimmer who is coming to us. We tell them, you go for swimming, and they tell the doctor, my pain is worsened. And we have to tell them that you need to have a proper swimming technique, educate the athlete about the biomechanics and injury prevention for this, various modalities which can really help for initial time for this. And strength training for swimmers is important, and there are lots and lots of benefits. It really boosts up your back and arm, shoulder and neck. Water pressure is equally distributed all over, and it's really gentle on your back. It's good for cardiac as well as risk for any other issue. We have to understand that if we keep ourselves fit, we really can talk about fitness to our patient and our family. And we really need to focus and give time, at least 40 minutes to 60 minutes for ourselves, at least 5 days. We just talk, but we don't do. And I think that is one of the important things which we all should consider doing. Thank you very much for patient hearing.
Dr. Shailesh, that was really, really, insightful and so informative. I didn't know that cycling has so much in it, even your position, your angle. I think it was really impressive. And I could see the passion which you have as a cyclist coming into your lecture. I really appreciate that. Really good.
Thank you, Dr. Nanda.
Last photo was very inspiring, sir. It is going to make me hit the gym tomorrow morning, because
and for all of us.
Yes, I agree with Dr. Ankur Nanda. I think Dr. Shailesh's passion and his experience as a triathlete, I think I could see that in the cycling, the swimming, and the running. Coming across, running and walking, of course, coming across strongly. So I guess, all in all, it was very interesting. Dr. Ankur Nanda, I was very impressed by your facility out there. And someday I would love to visit it. The machines were really impressive.
It will be a pleasure, ma'am. So we are also actually learning now how to use them better and better for our patients. And if you would ever want to come down, please, it will be such a pleasure to have you guys.
you so much, sir.
Thank you so much.
Thank you.
Thank you, everyone. Thank you for giving us a precious time. And if there are any queries, they can definitely SMS or WhatsApp to us. I really would like to thank the Pune Orthopedic Society for giving us a great opportunity on the World Spine Day to discuss with all of our colleagues today about sports and the health issues. Also, Sancheti Hospital for giving us this big platform for reaching out with all of you, and of course OrthoTV and Dr. Ashok Sham for a wonderful arrangement and outreach for this kind of academic activities. Thank you all, and stay safe, stay healthy. Thank you.
Thank you.